Dr. Jeevan Ladi, Dr. Prajakta Sambare, Dr. Sanjay Shah, and Dr. Arundhati Kalet. Please take the chairs.
Good morning, everybody. Let's start with the session now. May I have Dr. Sachin Kale? He's going to talk on uncooperative patient. Dr. Sachin, please.
A very good morning to all of you. A bit of a controversial topic, and I don't want to impress my views on anybody. Whether or not to do a topical phaco for uncooperative cataract surgery patient, it's personal choice. I have nothing to say about that. The video will run in the background. This was a lady on the list who was a normal patient for cataract surgery, having been draped, and this is what she's doing here. She's moving her eye a lot. With experience, you can manage these cases, but if you have done a proper pre-operative evaluation of the patient, I think there is no harm in giving a peribulbar, retrobulbar anesthesia to this patient. What you need to be careful about is use new blades. Your incisions have to be one shot. You can't keep doing incisions again and again. Patient is squeezing her eyes. I use intracameral anesthetic regularly, so I could stretch this pupil here. Blurex was used to visualize the capsule. This was a small pupil with a hard cataract. Wasn't decided for topical phaco, but it was just on the list, and to start with I thought I could manage this. Fixation of the eye, either you could do it with a small forceps there, or maybe the side port can be used for fixation. But every time you release your instrument, the eye is being squeezed. I use paracanine drops and intracameral oculan for intraoperative anesthesia. Once you can fix your eye, then the phaco isn't a problem here, because your left hand can push the eye downwards. The machine makes a lot of difference. The Centurion definitely gives you a lot of advantage in terms of IOP control and control over the procedure as well. But I think overall you can manage these cases under topical anesthesia. You have to be, you need to be a little prepared and a little patient while doing this. You will have ecchymosis, you'll have some chemosis, that's okay. But once you have a good chamber and a good fixation, I think these cases can be solved. One sec. We'll just, I think the video on this is not complete, so we'll run through what we've already seen. So we'll go ahead and we come to the irrigation aspiration stage. Be careful while coming out with your instruments. A thing which I could have done was I could have maybe used viscoelastic while coming out on the instruments. I think there's a problem with the video. It finishes there, I think so. So basically topical phaco in uncooperative patients is not a problem. When you've analyzed your patient well, trust in your patient, have the patient trust you. And I don't remember lately having given a block to the patient for cataract surgery, probably for the last more than 5 years or so. I think a very controversial topic again. I have nothing against anybody who gives a block for his patient. So I think that's it. Thank you.
Thanks, Sachin, for the excellent talk. As you know, in this session we are having a 4-minute practical talks, and we have Dr. Shailva Savda, who is going to deliver a keynote address. And you can say the key point of this session is Dr. Milind Mande, who is going to conduct a panel discussion on toric oil and their applications. I am sure it will be helpful to you.
Thank you, Sachin. We have next speaker, Dr. Navneet Toshniwal. He is a senior surgeon from Solapur, and I had an opportunity to get many important tips from him He has written many books and innovated many instruments in cataract. I present Dr. Navneet Toshniwal.
Good morning. First, at the outset, thankful to Dr. Prabhu Desai and all his team to invite me for this session. Usually we are talking most of the time in complications on a cornea and posterior capsule. One of the important structure which lies in between is the iris. So I wanted to put some highlights, and this is not as per se is a complication, it is the observation which I noticed in a huge training program from last 16 years I am doing. So this is the observation how the iris behave during the cases. Pointer please. Factors related to the iris behavior. It's a 4 minutes. So just see when the entry and if the wound is not good, how the iris starts coming out. Then if you will come out very slowly out of it, suddenly iris can come out in spite of a good incision. Now you are in the stage, and again you are going, when you are going to the 12 o'clock, suddenly chamber collapse. Now during the division, this is a very important thing that you hit the iris with any instrument. Now this is the pre-chopper also, chamber gets shallow, touching the iris. This is very important, how to avoid this touching and all. Now this is the hold and chop or eating. Suddenly you can see how the iris contract, and in the irrigation aspiration also you can see that water flow go behind, pushing the iris. Why it is important these findings? Suddenly iris pupil get constricted and then maybe difficulty for your toric and all that. If your axis is bigger than iris, then you can catch the iris. And then sometime when you are putting the PMMA IOL with a big incision, how to support. This is a very important tip at the end of the surgery also. You should go the tangential, not vertically to the wound, to avoid the iris should come out. And tapping of the lens, as everybody knows, is very important. Now you can see here, this is one of the doctor who is doing surgery, and iris was out, so I told him not to go in through that iris. Now how to settle? It is not very easy, just to put little bit quantity to get stuck up. Suddenly that settle the iris and the iris will come out from the main wound. And then to reposit it, no, not to put more. You have to, instead of that, you have to remove the visco out of it and then settle again the tangential, not vertical. Instrument handling is a very important key factor in this. Now you can go slowly, steadily, trying to catch, and you are doing the eye. Again, the iris which is stuck at the wound is a different shape, and it will continuously coming in the wound. Putting the foldable IOL also art, setting over the iris, press over the iris and put it. These are great observation. I was doing one of the VIP patient. I was trying to lift the second half and suddenly pupil gets small. This is the very typical finding. Irrigating fluid going behind the iris and suddenly the iris gets collapsed. After whatever the surgical hand you are having, these things are happening. So instead of putting the dilated, and I was continue just phaco in the center, and I was trying to do, but at irrigation aspiration I got stuck. And again the principle of the capsular axis and pupil size, it makes difference. So whatever you will do, it will suddenly get collapse and collapse. And then you have to be ready with the maybe dilated drops or iris hooks. So whatever the case may be, you cannot underestimate how the things will behave, how the iris will behave. Here I have taken this clip. After putting the iris shoes also, iris will become a behave differently. You have to push the iris back and then to enter, because chamber is uneven throughout the surgery, and then you can finish the case. So this is the very unique finding which I feel after over a period of training, that iris you have to give a lot of concentration, and instrumentation is the most important, and some principles of the anterior segment physics. Thank you. Thank you very much.
Dr. Navneet, thanks. Though he's a guest faculty, he's been a part of Poona Ophthalmological Society and doing a great job of teaching so many fellows, and we thank him for that. And may I request Dr. Mrs. Ambare ma'am to felicitate him with a token of appreciation.
Our next speaker is Dr. Ridhima Bhagli. She is a budding ophthalmologist who has done her post-graduation from Bhide Medical College and her fellowship in Narayan Netralaya and at King's College, London.
Thank you very much, ma'am. It's my pleasure to speak on cataract surgery in zonular dehiscence today. So there are 3 cases. The first 2 are quite rushed. I think we can start. Can you play the video, please? Yes. So the first case is a localized inferior coloboma with absent zonules for the inferior 3 clock hours, and the procedure is more or less the same. I had just planned to put in a CTR before phacoemulsification, and since it's not a progressive or generalized weakness, the surgery went on quite It was uneventful. The second case, about 4 clock hours, traumatic cataract with a mature cataract, but what happened here was I lost the rexus and I couldn't then put in a CTR. I've lifted it from the other side and completed it, but yeah, the bag is not, the integrity of the rexus is compromised, so I'm putting in 2 capsular hooks to stabilize the bag during phacoemulsification. Everything went fine, but I've put in a 3-piece intraocular lens in the bag since I don't have a CTR, and dialing the haptics such that it would be in the area of the zonular weakness. So this is a more extensive zonular dehiscence, about 5 clock hours of subluxated cataract. So ideally, your wound when you start off should be in an area of good zonules. Use a dispersive viscoelastic over the area to tampen out the vitreous. Start the rexus in the area again of good zonules. You may often need to use forceps and provide counter traction in the area of zonular weakness to be able to complete your rexus. Since it's an extensive dehiscence, I plan to put in a capsular tension segment, and that needs to be fixated to the scleral wall. So sorry you can't see it, but I've made a scleral pocket, and you need to pre-place a double arm tenoproline suture through the fixation hook or the eyelet, and I'm retrieving each arm of the tenoproline through the scleral pocket with the help of a 26 gauge needle. Here you need to be careful that you're not compromising the integrity of the bag. You cannot puncture the bag. Once the sutures are retrieved, the aim is that this capsular tension segment needs to be implanted in the bag, the 2 arms of the segment, and it needs to be centered in the area of zonular weakness. It has a fixation hook with an eyelet, and that will wrap around the rexus edge. So this will stabilize the bag during phacoemulsification. It's easier to put a segment as compared to a Sioni ring before phacoemulsification. That's the reason I've chosen to do this. There was some vitreous there that was hindering the proper placement of this segment, and hence I'm doing a vitrectomy in the area before positioning. So once the 2 arms are in the bag, the fixation hook needs to be over the rexus. Pull in the sutures, and I'm tying it under the scleral flap. You can see the bag is better centered, and then the phacoemulsification, make sure that there's a good hydrodissection, the nucleus is mobile, chop, low fluidics, slow cautious movements. I do have videos where I have failed to do a proper phacoemulsification. The whole bag is just coming into the phaco probe, and I've just converted the case and done a primary scleral fixated IOL but I have chosen to show my successful attempt here. After the phaco, a regular, because there's a segment, the bag is kind of pulled to one side, a CTR implantation to redistribute the zonular tension throughout the bag. I usually put it in at the end with the forceps, and a cortex aspiration with any IOL implantation of your choice in the bag then. So I think what I would say is that you need to be prepared in these cases to face a greater challenge than you would anticipate. You need to be prepared and ready for anything that may go wrong. and you should be prepared to change your plan of action depending on what the situation is on table. Thank you very much.
Thank you, Dr. Bhagli. May I now request our next speaker, Dr. Nilesh Uplenchwar. Dr. Nilesh has done his fellowship in phacoemulsification from Lions Nab Mirrors, and he is serving right now as a consultant in Dinanath Mangeshkar Hospital. He is a very dynamic surgeon, Dr. Nilesh Uplenchwar.
Good morning, everybody. At the outset, I would thank Poona Ophthalmological Society for giving me this opportunity to show you my work on small pupil management. In the next 4 minutes, I will be showing you around 3 to 4 cases. We start the videos. These are usually the very plastered iris in uveitis cases. The management needs a micro MVR knife to gently separate the membrane. The chamber should be filled with viscoelastic to give a proper space. If you are doing under topical anesthesia, it's a better thing to stabilize the globe through the second side port. The membrane is rigid. It usually avoids the damage to the sphincter. The ends are changed so that you can cut the membrane from the opposite ends. Iris spatula is then used to separate the posterior synechia from the membranes. A 2Y is the most convenient and the most safest, easiest way to learn. 2Y hooks are Y dialers are used. It's engaged at the pupillary margin and it is gently stretched to the opposite end. It causes microsphincterotomies. The side effect is you get small bleeding, but the pupil is fairly large enough. If you can make a capsulorhexis, the surgery can be done very easily. This method can also be tried in cases with such cases like with a corneal opacity where you can get a clear space. The chamber should always be filled with viscoelastic. The movement should be very gentle to see the amount of tear which occurs at the pupillary margin. Once properly dilated, the case becomes very simple. In spite of doing this, if the pupil is still not getting, or if the pupil is really rigid, then these iris hooks can be used. These are nylon filaments or proline filaments with a hook at one end and a silicone sleeve which can be adjusted at the limbus to block the site of the you get a square pupil. And in this case, the advantage is you can adjust the size of mydriasis which is required. So if you feel the pupil is getting overstretched, the trick is to make the side port paracentesis incision at the limbus so that you don't get lifting of the iris. Otherwise, you get an irregular anterior chamber as shown by Dr. Toshniwal. The third case you can use, if the pupil is really elastic, you can use a Maligan ring or a BX pupil dilator. This has flanges and alternate flanges. It can be inserted through a 2.2 millimeter incision as you have seen. These notches are then tucked below the pupil. It's very easily goes if the pupil is elastic, but if the pupil is rigid, it causes slight deformation. Then you need a second instrument to adjust the ring. Once inserted properly, you get a hexagonal 5.5 millimeters pupil. This pupil remains quite stable during surgery. Once the pupil is around 5 millimeters or 4.5 to 5 millimeters, the other steps are as usual. But in small pupil, try to do the phacoemulsification with low parameters, keeping the probe exactly in the center, and all the movements should be preferably under your vision. A foldable IL can easily be implanted in all these cases. If the zonules are weak, a 3-piece IL suits the purpose. The ring can be easily removed by untucking the flanges. It can be easily removed with a McPherson forceps by gently pulling it out through the 2.2 millimeters central incision. You get a fairly circular pupil in all these cases without much mydriasis, post-op mydriasis. Thank you.
Thanks, Dr. Nilesh. Nilesh is an amazing surgeon practicing in Pune. May I request Dr. Rahul Deshpande to talk on mature, hypermature cataract management. Apart from cataract surgery, Dr. Rahul has done extensive work in oculoplasty and low visual aids. Amazing surgeon, does a high volume surgeries, and one of the director in HV Desai Hospital. Dr. Rahul, please. Thank you.
Good morning, everyone. I'm thankful to the organizers for giving me the opportunity to give this presentation. So I will be dealing with the hypermature and the mature cataracts. Initially, one or the two slides are the introductory slides. Then we can shift to the video. Then now see these figures. Now this type of cataract seems to be very easy to perform, but while doing, the catastrophe can occur and you can land up in problem. So you promise the patient that you will be putting the lens, we'll do more rewarding surgery, but while doing, you can crop up with complications in such type of cataracts. This seems to be very easy, but many a times there can be a phacodonesis, there can be a subluxation of the lens. But while doing surgery, you can come to know that there is definitely this type of problems which are encountered. Now the problems are hard nucleus, absence of epinucleus and cortex, presence of a thin fragile capsule, a high intracapsular pressure, liquefied cortex, long phaco time or endothelial damage. These are the practical problems. A biometry, a B scan is always essential, and IR power calculation has to be precise in such cases. Now the standby things are that CTR ring should be a standby thing, because you may never know that there can be a zonular dehiscence and you can land up in problem in delivering this type of cataracts. Then the capsule can, the capsulotomy can be extremely difficult, Triffan blue, and all the essential high-end viscoelastic is always required while doing a capsulorhexis in such type of cataracts. Now the capsulotomies, either you can do a CCC, envelope technique, can opener technique, whichever you are accustomed to. Many a time CCC becomes very difficult in such cases. Slowly you have to do CCC, first you have to make a small CCC, then later on you can enlarge it. If you try to do a bigger type of CCC, the extension can occur and you can land up with a problem. So the most dead end sign is while during the CCC that the capsule can break, and then you can have this sort of a problem in that. We can shift to the video, please. So while doing a phacoemulsification in this site of a cataract is a grade 4 hard cataract. Now always remember, you have to, while doing the capsulorhexis, use a high-end viscoelastic so that the chamber is very stable, and you do a small, try to do a small CCC in this case, as you want to do a phaco in this case. So later on you can increase the size of the CCC. As I told you earlier, if you do a bigger size of CCC, it can extend and you can land up in problem. A high end of a viscoelastic, a high visc or a Helon can be used so that the chamber stability becomes good. The hydrodissection has to be very precise, because suddenly if you do hydrodissection, the nucleus can tumble, or then there can be a rent and you can land up in problem. So while doing a trenching, either you can do a direct chop or you can do a by the stop and chop technique. Preferably in mature or hard cataracts, I use 2 dialers, so the adequate breakage or the separation occurs. Many a times with phaco probe and the only dialer, sometimes it becomes difficult because the posterior plate is very strong. Then slowly you are emulsifying the pieces. You are doing, I am doing the stop and chop technique in this. Then after emulsifying the nucleus, again the cortex or the epinucleus, with the phaco 3 you can aspirate. With the bimanual you can slowly remove the cortex. Be gentle while removing cortex, because while removing the cortex sometimes it may adhere to the capsule and you can produce a zonular dialysis while removing the cortex. Again after implantation of the lens, be careful, because dialing has to be precise, because haphazard dialing or extra manipulation again can distort the capsule and you can land up with problem. So these are the practical problems while doing phaco in these cases. Now many a times with these brown cataracts or hard cataracts, sometimes if you are not confident or you want to see that rent doesn't occur, you switch over to the small incision also. Or if one big piece is there, don't have ego in mind that you do phaco in all cases. Basically the outcome has to be good.
The patient is not interested, you are doing phaco in such sort of a difficult cataracts, or you are doing a small incision, but the outcome without sutures, putting the lens in the bag without compromising the cornea and producing a PC rent, that should be the outcome in such cases. So we have to keep our ego aside, and we have to see from the patient's perspective that he wants, or we should give him a good vision. So in summary, the machine matters. High-end phaco machines, particularly cold phacos and all, are very suitable for this sort of a cataracts. Be endothelial friendly, so soft cell techniques sometimes can be used. Be prepared with the mydriatic agents, iris retractor, CTR rings before starting surgery. So these are the main key points while doing, and be gentle and try to convert whenever the catastrophe or you are encountering in your procedure. Thank you.
Thank you, Rahul, for giving excellent and important tips for managing hypermature and mature cataracts. Our next speaker is Dr. Sandesh Doshi. He will be talking to us on PC rent management. He is a senior vitreoretinal surgeon from Pune. Dr. Sandesh, please.
Good morning, guys. Thank you, Poona Ophthalmological Society, for giving me this opportunity. I have modified my talk to include nucleus drop management, because I think that is the worst complication that a surgeon can think of. And if you know how to manage that complication, then I think the panicky situation that you arrive when you have any PC rent as such is not that a serious complication if managed properly. It is a complication which causes visual problems. Since the time is limited, I'll straight away go to my video. Now this is a nucleus drop. The referring surgeon, as soon as he was doing a CCC, after CCC, when he was doing hydrodissection, the entire nucleus fell down. It was absolutely white cataract. He came to me after 15 days later, so the pupil was constricted and there were signs of inflammation, and so I had to use iris retractors. Yes, you see, you can, there's a full mature cataract inside. I used perfluorocarbon, since I am doing routinely perfluorocarbon during my vitreoretinal surgery. I used perfluorocarbon to support the posterior pole. I removed the cortex, whatever was left with, and with a phaco fragmentation 20 gauge needle, I applied the aspiration, brought this nucleus piece into the mid vitreous cavity or anterior vitreous cavity, and applied the energy. And patience is the key here. There is no hurry. We were doing this. This was a one-eyed patient, by the way. And the referring surgeon had also sent the lens along with him, the rigid lens that he was planning to put. So I will rush through the video now. Where is that? Now as you see, the nucleus keeps on getting smaller and smaller with phacofragmentation. Now very small particles of nucleus are remaining. And then I would use Kinacort just to ensure that I have removed the entire vitreous, because entire vitreous must be removed. It is a traction which can cause future complications. So I am going very close to the retina, removing whatever vitreous I think there could be. And then I do not forget to examine the periphery, because it is often the missed peripheral break can cause complications. So I spend significant time to indent and check the periphery. Luckily the periphery was normal, so we didn't do any and this is a insertion of the lens. I think this was plus 15 or 14. Luckily CC was intact, so I just put this lens into the sulcus over the CCC and took the sutures. So because the patient was referred without any handling from the referring surgeon, this patient I think was operated 14 years back, and till today he comes every yearly and he maintains 6-12 vision with the glasses. Now I'll quickly go through my slides, and you can ask me to stop anytime my time is over. So the take home message is PC rent, if you happen at any stage, it can happen immediately after you do hydrodissection, or it can happen during cataract emulsification, or that the last piece, or even at the end of the in irrigation aspiration. My point is that do not panic. As such, that complication does not cause any problem, but you should accept the situation, explain to the patient, and be prepared to operate this patient at a next date. I normally would prefer to operate the vitrectomy surgery on a third day. So you get 1 day to plan for appropriate things. If you have an additional setup where everything is ready, then you can immediately convert into the vitreoretinal surgery and get over it. But whenever you have a complication, manage whatever nucleus you can take it out with the phaco. Make sure that you do not suck the vitreous, because it is the traction over the vitreous which can cause retinal detachment, and once you have a problem, then you are in a deep trouble. Thank you very much, sir.
Thank you, Sandesh. Our next speaker is Dr. Shail Vasavda. He completed his post-graduation from Ahmedabad and did his fellowship from Raghudeep Eye Institute and Lelvi Prasad Eye Hospital, and did his fellowship in cataract and refractive surgery at prestigious Moron Eye Center, USA. He is currently working as consultant ophthalmologist at Raghudeep Eye Hospital with a special interest in newer advanced techniques and technology in cataract surgery, particularly femtosecond cataract surgery. He has many awards to his credits. I present Dr. Shail Vasavda to his present talk.
Thank you very much, sir, for the kind introduction, and thank you to the Poona Ophthalmological Society for the invitation. The previous talk by Dr. Doshi reminded me of a very nice quote that one of my teachers told me, that whenever you have a drop nucleus or a sinking fragment, just remember the bye-bye technique as a cataract surgeon, that let it go rather than trying to fish it, because trying to fishing it causes more problems. So moving on to, more and more, all of us are getting more and more involved with gadgets, and when I started MBBS, which was not very far ago, we always thought radiology is the technology branch, new machines, MRI, CTs, and it's the most expensive branch, things like that. And now over the past decade, I think ophthalmology has surpassed probably all branches in medicine with the evolution or the upgradation of various forms of technology, and image guidance in cataract surgery is one of them. There are, I think, 2 or 3 current platforms which are using image guided. I have experience using the Varion, and I do acknowledge that our hospital does receive research grant support from time to time from Alcon Laboratories. So the first question that whenever any new technology comes up is, we must question that why do we need such a thing, and is it really necessary, or is this just a marketing gimmick that has been brought out? So why image guided? And this is something that really helped us to open up our eyes. This is a nice application on the iPhone designed by Dr. Graham Barrett called the Toric Cam, which helps us to analyze our manual markings. I believe there are now quite a few Android-based apps also for the same. So what you do here, you do your presumably perfect 0-180 marks, and then this app uses the iPhone's gyroscope to actually tell us how much off your 0 and 180 is. And we found that in almost 9 out of 10 cases, or almost 10 out of 10, we were at least off by 2 to 5 degrees, and on what we thought was 0 or what we thought was 180. This is an ideal case scenario of how to mark a case of toric IOL. I'm sorry. Yeah. Really sorry for the trouble. I'll just turn it to full screen. So I don't know, somehow it's working here, running in the laptop, but not to go. Yeah. So you ideally would want to mark and dry the area where you're actually going to place the mark, and this is the ideal way to do that. And if you are dried up, you can make sure that there is no fluid that seeps in from the fornices, and you get what you know as this ideal sharp mark. And now typically we just use the one mark on the side proximal to the surgeon. But very often we just start up with this, with a blotched up 180-degree mark. Or if you are not careful in making or wiping off some of the fluid, if you notice here, some of the fluid has seeped in through the fornices into the Mendes ring, and this is what you quite often end up. So not all cases that we always show is the reality, and this often turns out to be the reality. The second question that most individuals ask us, that is this just a fancy digital marker that Varion or Callisto or all of these devices that have come up with different companies? So no, I believe this is a step ahead from just being a sophisticated computerized digital marker, because it helps us to not only plan preoperatively but also design our plan intraoperatively. And this is one thing that all of us have ignored over the years, that just from sitting to sleeping position, or with various head tilts of the patient sitting on a particular measuring device, there can be a cyclotorsion of up to 8 to 10 degrees. So this is the patient who is sitting, say, on a lens star, and you are busy looking at the screen, not realizing how his head has actually changed or tilted on the other side of the machine, and this itself can lead to an axis changing of about 8 to 10 degrees. So take into example this same patient. This is the same patient, the same eye, with various forms of head tilt. With this head position, you measure the steep axis at 135, and with a slight head tilt, you measure the steep axis at as different as 155. So this is something that often gets unnoticed, and it's almost impossible to get an absolutely perfect head alignment in all patients at all times. Whereas if you consider any form of image guided technique, the number of that degree does not matter, because it is in reference to the steep axis. So all of this is the same patient, the three eyes are of the same patient, although the number is different because of the head tilt, the actual positioning of the IOL will be the same, because it is in reference with the episcleral vessels and the steep axis. Therefore it takes care of the cyclotorsion, and cyclotorsion is known to affect the positioning and improper axis alignment or improper axis selection in toric IOLs, and different methods of compensating cyclotorsion, including the digital marking systems, have shown to improve or enhance the axis placement. The other thing that it helps us now, particularly with the newer Barrett software being incorporated into the Varion, is it gives you good planning material as well. So right from looking at the screen, if you require a toric IOL, if the patient has sufficient astigmatism, it will show up with this bar which tells us that you require, it gives us a warning, say yellow, red, depending on how much the cylinder the patient has. It also now incorporates the Barrett algorithm for toric calculation. That is, now you don't need to worry about what the posterior corneal astigmatism of this patient is or is likely to affect in the calculations, because this algorithm has shown to be even more effective than actually using the posterior corneal values from the pentacam. So it helps us to use the newest formula, the most effective formula, and choose the optimal power. And it also gives us the option of choosing different formulas. You can have your own choice of formulas, and you can compare what the power in this patient would be with the different formulas. It also has inbuilt software for the post-refractive Barrett formula. That is, you don't necessarily now need to go to the ASCRS website to go in and manually feed all the data. All the data that is captured can be used to calculate the post-refractive eyes as well. Now, once having captured all of the data, now is the time to actually use it inside the operating room. And if you have access to femtosecond, you can link it even to the femtosecond technique, so that your incision, while after docking, quite often the eye cyclo rotates just because of the dock itself, the pressure of the dock. So your incision, although you may have wanted to keep it slightly on the right, can become slightly on the left, making it awkward during surgery. And if you have linked it to your Varion, then it compares the pre-doc to the post-doc image and allows and compensates for the cyclotorsion. So this is how you start your case. You actually compare the pre-operatively registered mark with the intraoperative image, and it sort of registers the eye along with that. And then you move on to the actual surgery. It also gives you a guide as to the incision placement, so you know exactly where your incision is, whether it's actually 90, 180, 10 degrees, what you think. So it gives you an incision guide as well. It also allows you to create rexes of optimal size, and this one feature is something I like very much. So it sort of gives you a digital guide. So there are, I know, various corneal markers and impression devices as well, but this is real time. Even with the eye moving, some of the corneal marks can blotch up, hamper your view during cataract surgery. So here you can choose the centration of the rexes, the size of the rexes. For example, if it's a young patient, myopic patient, you want to keep a slightly smaller rexes size. In an older or a denser cataract, you may want to keep a slightly larger rexes size. So it allows you to, this acts as a guideline to follow to create an optimal rexes of an appropriate size and an appropriate centration. And I think this is one of the features I like the most. This is the feature for which it was actually supposed to be built for, and that is the IOL implantation and aligning the IOL. And like you noticed here, now there are no 0, 180 marks or any sort of marks that have been made here. This is something that you see through your eyepiece of the microscope. So you can keep it on the display as well on the screen, but this is something that the surgeon sees through the eyepiece. What we typically like to do is leave the IOL in the horizontal position because it allows good viscoelastic removal from behind the bag, which is absolutely essential for placing toric IOLs. And for those who are using bimanual irrigation aspiration, you can use the same bimanual IA probes in a polish mode, that is the lowest vacuum and lowest flow rate, to then dial this IOL into position. Because of the parallax, it's almost impossible to align both sides of the marks. So the Varion, the best part is if those marks are parallel to each other, parallel to the lines, it means you are in the correct position. The final question that I think all of us should ask is that if I buy this one, or if I have this one equipment, can I use this as a standalone instrument to start toric IOLs, or to use it as a standalone instrument for my toric IOL practice? And I think with these newer softwares and the newer algorithms where it helps us to plan and treat pre-operatively to intraoperatively, we did our own data analysis to find that we are getting at least 75% of our cases within half a diopter, and I think somewhere between 70 to 80% if you get in half a diopter is considered to be a gold standard with the current way that we are treating astigmatism. But with the use of Varion, if you notice, our use of lower astigmatism correction has increased because now we are more confident in planning and treating them. Therefore, the T2, T3 models have increased significantly. If you notice, 65% of the IOLs that we are using now are T2 and T3 models, and like I said, less than half a diopter we could achieve in 75 degrees. This was a review published by the American Academy which showed that even for lower astigmatism less than 1 diopter, toric IOLs leave behind lesser post-op astigmatism and are more predictable compared to even limbal relaxing incisions. However, we must remember, like I showed in the data, that 0 is something ideal but not possible in most situations. And you can use these image guided systems even in non-cataract cases like ICL, like toric ICLs. You can use, instead of marking, you can use the Varion to actually place and plan the toric ICL as per the axis. So I think all in all, it's easy, user friendly. I think that is something that is most important. All of us are looking to reduce as much of manual errors as much as possible. With the newer softwares, newer formula and improving accuracies, I think that's definitely a step ahead. And I think in the coming times, it's definitely going to become a part and parcel of our routine clinical practice, like toric IOL has now become a part and parcel of cataract practice almost all over the world. Similarly, I think in the coming times, some or the other forms of digital or image guided techniques are going to become part and parcel of routine clinical practice. Thank you once again for the attention, and I apologize for the audio visual
Thank you, Dr. Shell. I request Dr. Arundhati to felicitate Dr. Shell Vasavda.
And now we come to the key part of this session. Dr. Milind Pandey is going to conduct a panel discussion on toric IOL and their applications. May I request the panelists to come on a first line, and can we have a floating mic here? We have Dr. Kishore Pahuja. Respected Dr. Sarvate has come all the way from Satara. Amazing academician, a great surgeon. We welcome Dr. Sarvate, Dr. Sanjay Tekawade, and Dr. Shail Vasavda. Dr. Milind Pandey heads the Vision Surgery Research Center in East Yorkshire. He was over 35 years of clinical and surgical experience in 3 continents with subspecialty experience in cataract, cornea, and refractive surgery. You need to work in the field of refractive cataract surgery, lens section surgery, laser vision surgery are the things which he's been doing for such a long time. Whether it is organizing annual state conference, art of refractive surgery, cataract surgery symposium in Hull, running a surgical workshop in India, lecturing in China, Europe, Africa, America, teaching in a passion. His peers have honored him with the numerous invitations to demonstrate his surgical technique via live telecast, satellite transmission at national and international conferences. Other honor includes membership of the International Intraocular Club, International Select Group of Pioneers of Vision Correction Surgery. He trained initially in Yorkshire before taking up the prestigious Iris Fund Research Fellowship at St. Thomas Hospital in London. He was a lecturer in Oxford before joining the Hull Royal Infirmary as a consultant. He is past president of the United Kingdom and Ireland Society of Cataract and Refractive Surgeons and past member of Laser Eye Surgery Committee of the Royal College of Ophthalmologists. A leader in his profession, he is respected for his clinical experience, surgical skills, his dedication to sensitive patient focused care. His reputation has attached many patients all over the world from Europe, Africa, Asia and Caribbean. May I present to you Dr. Milind Pandey, please.
Thank you, Jeevan. Thank you for the kind introduction and thank you for this wonderful invitation. It's always nice to be back in Poona. Apart from seeing friends, I also get to see my parents who happen to live here for the last 10 years now. So this is the part of England I live in. This is the River Humber, and here is the clinic complex. So this is a drone video from taken from my garden in the back, and we overlook this river, and it's a lovely part of England to be in. And I've been there now for more than 20 years, that specific place. And what I thought we'll do today was to have some fun with some toric IOLs. So let's first of all, in the audience, how many people use toric IOLs routinely in their practice? Multifocal IOLs? Extended range of vision? All of the above? None of the above. Okay. Indeed. So this is what cataract surgery is, and you could look at it in different ways. You have basic cataract surgery, or standard phaco is what I call it. Well, here all we're doing is we're restoring the transparency of the lens. When you start thinking of the refractive aspects, you can get up to the refractive cataract surgery side of it, which is to get good uncorrected distance vision. So here you're correcting the astigmatism, you're correcting the sphere accurately, and then what I call advanced refractive cataract surgery is apart from astigmatism and sphere, you're also correcting presbyopia. And we now have a whole range of options available to us to try and correct this. You can do it monovision, multifocals, extended range of vision, and multiple ways of doing it. But whichever way you do this, it is all about precision targeting. So you have to target the refractive error correctly. And this gentleman here, I think, is a really good precision targeting. And even he sometimes gets a refractive surprise. But he managed to correct it and do some more and get a good result. So I think we should learn from him. We should learn from him how to manage this whole thing. There is a hierarchy. There is a hierarchy of targeting. There's no point in getting your presbyopia correct if you're off on the sphere. It just doesn't work because the patient won't get any benefit off it. So what we really want to do is to get the sphere right first, the spherical target, then the cylinder, and once you've got those two right, only then will you start thinking of presbyopia corrections, otherwise the patients won't see the benefit of it. So what do we expect with our spherical targeting? I'm not going to spend too much time on this, but these are my results. We have an ongoing database where we monitor each and every patient that goes through, and it's fed through. And since we started with the catalyst about 18 months ago, our numbers have gone up from plus minus 0.5 from 91.5% to almost 95%, which is basically what we can get at the maximum levels with current technology. So what we're going to talk about is toric IOLs, and which of the following reasons do you think is for not using toric IOLs? Ranjana, you're the only one. Why not use toric IOLs? Is it because
my patients want free treatment from my medical college.
Okay,
they
so
will not spend a single
so
pay.
affordability is really what you're talking about. So, but if you could afford it, is there any reason? A lot of people say patients live with the astigmatism all their life, so why worry about it? Okay. Some would say it's too complex. You have to measure and you got to do all kinds of things. You got to do fancy calculations, and then all the marking. It's just too complex. I'm not going to do this. And then how do you manage any complications? That's the other thing that always comes up. So I put this up and I asked people, how many people understand this? Well, if you understand binary language, you will understand this. And what we're going to go through is to talk about these 5 aspects of toric IOLs, and we'll have it as a panel discussion so that we get views from everyone and also what happens. So corneal astigmatism in 30% of patients undergoing cataract surgery is more than a diopter, while 60% of patients have more than half a diopter. So it's something which is relevant for almost all patients that we have to go through. So the first thing comes, when you want to do targeting, what is the refractive astigmatic target you're going to aim for? Jeevan?
I would say anywhere between minus plus 0.25 to 0.5.
Okay. Maximum half a diopter.
Half a diopter.
Shall?
Closest to 0. Closest to 0, whatever.
Okay. So when you say closest to 0, when you do a refraction, what's the variability when you do a subjective refraction? It's half a diopter. So shall we agree on half a diopter? Okay.
I use 0.75 diopters.
0.75 diopters. That's great.
Yeah, 0.5 diopters, I would say.
Okay. And what about the meridian? What's the target for the meridian? Do you aim to swing the meridian? Do you aim to keep the meridian at 90 degrees or 180 degrees or what? Well, what's the usual situation?
I think what he's saying is basically, as there is a age 45 onwards, there is a more shift of astigmatism towards the with the rule, that is horizontally. So do we undercorrect vertical to allow that to happen? In my practice, I don't. The patient who comes with what refractive error, I treat that at that time.
Okay.
I don't contemplate, don't plan for 10-15 years afterwards what's going to happen.
Okay. So the question then comes, if you do half diopter as a target, but if you switch, if you overcorrect by half diopter, you're going to flip the meridian.
No?
Yes.
Yeah. Achha, okay.
So you'll go from 90 to 180.
180.
The question then comes, does the patient's neuroadaptation work the same way? Which is why one of the things people say you should always undercorrect rather than overcorrect. But then what we talk about is corneal astigmatism here and not refractive astigmatism. And at half a diopter, I don't think it makes a difference. But the major reason people talk about to leave it at with the rule astigmatism is you get a bit of drift with it. Plus, you can also accommodate for posterior corneal astigmatism, which is what we'll talk about further down the line. So, I agree with you. I think half diopter is really what we should aim for, and what we aim for, and this is what I do. Half diopter of refractive astigmatism without changing the meridian. So the idea is you try and undercorrect if you can, or half diopter of with the rule astigmatism so that you protect for some drift. So whichever way you take, I think it works well in that situation.
Just one
Sure.
point. One important thing that all of us need to understand is that this half a diopter is at the end of your calculation. So you must account for your surgically induced astigmatism and with the rule against the rule.
We'll come to that.
Yeah.
This is what you want the patient to end up with.
Your target. We are talking about target.
This is the target
not the
that we're going
calculation.
to go for. That's right. So let's have a look at this particular clinical situation. This is a 52-year-old female patient who is using gas-permeable contact lenses for monovision. Poor tolerance due to dry eyes. She had monovision lens exchange surgery was the plan. For that's a refraction as such. And when you measure, you get on the IOL master 1.6 diopters at 93, on topography 1.15 at 98. And when we did this particular correction for her, this is what she ended up with, minus 2.25, plus 1.5, 178. What happened? So you get this patient here. What's the first thing you would like to do? What are the kind of information that you would go for? So the patient's been overcorrected.
Yeah, but in this patient, was the posterior corneal astigmatism considered in this patient? Calculated?
So let me show you what, the op scan before and after. So this is the topography before, preoperatively. This is the topography after, preoperatively, after surgery. And you notice that there's a big difference in the amount of astigmatism that's been measured as such. So this is basically a measurement error that we ended up with.
Okay.
And that's the reason why this patient was overcorrected. So then before doing the other eye, you obviously want to see whether the same things happen to the other eye or not. And not surprisingly, the same thing had happened in the sense. So you learn from how the first eye behaved to then apply that knowledge to the second eye to make sure that you don't have the same problem again. 4 weeks post-op, this is what the patient's refraction is. So what would you do? Any takers? Anyone?
In this patient, I would like to rotate the IOL first because that would give
So
good results.
rotation on the IOL.
I think there's a significant spherical error difference as well. So the spherical equivalent I think comes up to be about 1.5 or so.
Yes.
So I think in the early post-op, maybe rotation can be considered as an option, but I don't think it's going to take care of all of the error. Yeah.
Any other
Dr.
comments?
Sarvati sir? Sanjay, can you come on
Was
this
there any
side,
problem with the dry eye which was causing this?
We'll come to that.
No, but the question is why you want to have a rotation when you have realized that there was an error in your pre-op calculations.
Okay.
So why you want to have a rotation for that? So you have to consider that and treat that.
So you would do an exchange?
No. I mean, first I'll understand that whether after doing that, I mean, probably I have an eye trace, so I can just do that and calculate it how much the over astigmatism there. If I have to correct it, either I'll do a lens exchange or probably do a bioptics.
Okay.
Sanjay?
Yeah, after rotation, whatever residual astigmatism is there, and if the patient is not comfortable, bioptics.
Okay. So everyone's going to do something to put the lens back in the correct place, so to correct this astigmatism. The patient was very happy because she could read without glasses. Are you still going to correct anything?
The reason may be because of an spherical equivalent that is having and is on the minus
Indeed.
side.
Yes.
That could be the only reason for
yes.
this. Yeah.
So that myopia and that amount of astigmatism, the patient is getting the reading and she says, this is wonderful. So there's no point in doing anything, is there? But you've learned for the other eye that you have to nail the distance correctly now. And because you identified the measurement error, we did that, and patient ended up with 20 happy, as they say, successful accidental monovision.
One thing I would just add, when we did not have toric lenses, when we left cylinder at 90 degrees, what is here, minus, patients were very happy reading.
Yeah, it's a vertical coma basically, which helps you to see the near things quite well. But still, I would like to ask this question: what do you feel happened in the first eye? Means what happened?
It's a measurement error.
It's a measurement. Okay.
It's a measurement error. So we know measurement of corneal astigmatism can be a big issue, and there are various factors that can influence it. And to identify those factors, I feel corneal topography is absolutely critical for anyone who's doing toric IOLs. Would anyone disagree with that? Would anyone?
Absolutely.
Okay. So the factors that give you measurement errors are these. You get dry eye, a very common thing, irregular astigmatism, asymmetric bow ties, keratoconus, pellucid marginal, and contact lens users. So you have to be aware of all these factors as such. So does anyone in the panel actually take any special measures, or how do you identify preoperatively whether there are any measurement errors? What kind of, do you take any special steps when you look at topography, whatever?
I think let's talk about the era which is 1 year since now and 1 year before. When we are feeding the data to other companies, they were not having posterior corneal astigmatism calculated in their nomograms. So what we did, we had to do a calculation on our own.
No, we're not talking of calculation, we're talking of measurement.
Measurement will come
so
only
if
once.
you measure incorrectly, your calculations might be right, you'll still end up with the wrong answer.
Yes.
Correct.
So
now the question here is, what he is saying is that whether you do anything pre-operatively to understand that whether any of this is there. Am I correct?
So how do you check
How do
whether
you check
your
that
measurements are good enough to do further calculations with? That's really what my question is.
I think optical bio. Sorry.
Okay. So we do it, I mean, a week apart, 2 readings, and if both the readings match it, and also the 3K we do it, which is within a topography, eye trace, and then a manual K. If all 3 are same, then probably we'll take that reading as a correct
So you
reading.
take multiple measurements across time and across devices as such.
Yes.
And if they don't agree?
If they don't agree, I just give another 1 week, or then we assess for a dry eye and treat that for at least about 2 weeks, and then we do the measurements again.
Sure.
I think it's what you have available. Like what we do is automated keratometry, optical biometry, K on optical biometry, and again Schimflug imaging. On Schimflug imaging, what we are trying to say, is it a regular astigmatism? Anything else is there onto the map? Then apart from what we are going to miss, and then we see that astigmatism pattern which is there into the topography of Schimflug imaging, and we compare it with the optical biometer, and then take a call.
Okay. So
no, if the Schimflug imaging is okay and everything is okay, then only then also we would like to see the dry eye pattern, especially in these contact lens users, and we'll have to take those measurements after the dry eye is being corrected, and then that might improve quite a bit.
Sure. So all patients who have dry eyes, you get variability in the measurement appointment. So one of the things we started doing over the last year in the practice is we pre-treat every patient before they come in for their measurements for a week with lubricants to optimize the ocular surface and then reduce the chances of getting these kind of errors. But whatever you do, you'll always get some of these.
Preservative free or with preservative? Lubricating drops with preservative, without preservative?
Preservative free.
Preservative.
All drops that we use are preservative free. What happened there? It cut off.
Practically it doesn't happen in a place like India. The reason being that so much of a planning is not there. Many times people come with the reports and fitness and operators tomorrow.
Sure.
You know?
Sure.
And our mouth is watering so much, we can't say wait for 1 week. You know.
This happens. This happens all over the world.
Yeah, well, thank you.
Except in my practice. Because I have a bit of a strange practice where the cost doesn't matter, time doesn't matter, and it's done on my terms, or the patient goes somewhere else. I don't give a damn.
I won't.
So let's talk about posterior corneal astigmatism and aligned curvatures. We know that if the posterior corneal curvature is aligned to the anterior corneal curvature, because it's a negative power, it reduces the amount of total corneal astigmatism. Well, if you have cross-aligned, then it adds to the corneal astigmatism as such that you have to treat. So this is something, again, on corneal topography people look for, and you should look for it as such. Corneal refractive surgery, this is a problem I find, it's a very difficult thing to solve at times, is patients had good vision after corneal laser surgery. You look at the corneas and they have significant astigmatism. Now, we know you can't really rely on those topographies and optical biometries for all these reasons as such, but what do you do? What's your approach in this, Shell?
So for post-refractive, I think it's even more important to take multiple readings from multiple instruments. And I think the strategy that we have found most useful is to collect as much data as much as we can and then just feed it into the ASCRS calculator. Out of the various formulas that sort of come up, our preference is sort of more for the Sharma's or the Barrett's True K.
I'm not talking of the spherical targeting here at all.
Okay.
I'm talking about the astigmatic target.
Okay.
Okay. So there's no formula
So
on
I
the
think
ASCRS.
no, absolutely. So I think if the
It's not there.
astigmatism, if it is a regular astigmatism on topography, I think two important things that we need to look at. Sometimes, like if you see in this map, if you broadly look at it, you find that it's probably not so regular all around and probably slight decentration. But if you actually zoom into the pupillary area of the patient, it's important to know the mesopic pupil size of the patient. And in India, most Asian population are blessed with a smaller mesopic pupil size. So if within about 3 millimeters of the pupil size, if the astigmatism is regular, I think there should be no hesitation in considering the patient for a toric IOL.
So you're quite happy to accept the corneal topography astigmatism in corneas which have been treated with corneal refractive surgery in the past?
Not to actually measure the magnitude, but if it is to look for the regularity. So if it's regular, I would rely on the values of the biometer. But if it's regular, that is something I would definitely rely on the topographer to consider.
My personal protocol is that my target in post-refractive surgery is not astigmatism. My target is a spherical error. And I tell patient, and we put multifocal eye also, but not toric multifocal. We tell them that the astigmatism is part that we are not going to work in this calculation. We'll wait 3 months after surgery and we'll correct it.
Okay. So you'll do it as a two-step bioptics procedure.
Correct.
Okay.
Why I don't want to do it, we have been calculating with Sharma's equation for more than 15 years now, since its inception, and we have been putting routinely multifocal IOLs post PRK and LASIK, and now SMILE. But in that calculation, astigmatism is not considered. Whatever average K comes, we put through the calculation and we go back to our machine and feed that data as average K as a K1 and K2.
I agree with you. I agree
Patient.
with you. It's a difficult challenge because patients see well. You take the history and they say, I've had surgery 10 years ago, everything was absolutely fine. You put them on the topography and you put them on keratometry and they have 2 diopters of astigmatism. And you say, okay, what are you going to do? Are you going to reduce this or not? And it's a difficult one. But when in doubt, I think that's a good strategy to have, is to do it as a 2-stage thing. So you base the post-operative correction purely on the refraction rather than your keratometry as such.
Just as a small addition, that the Barrett now also has the toric for the post-refractive.
We'll come to
that
Barrett
makes,
too.
One issue is also post-RK. I think that's...
Yes, all abnormal corneas. So let's move on to the actual calculations now. There are various factors which influence those calculations, which we have to input into the calculator. One is surgically induced astigmatism. Do everyone in the panel know what the surgically induced astigmatism is?
Yes. Yeah, we know. And basically now we are beyond that. We are beyond SI to centroid value. and we feed
How
it as
have
a
you
1.2
measured
to 1.4.
it? How have you measured
It's
it?
a basically average, your own average of post-op patients, which you have to calculate and plot it and come to a conclusion. Okay, this is what it is going to be.
Okay.
But if you don't have any values which are calculated, then what we feed is 1.2 or 1.4.
Okay.
I think until a couple of years ago, we used to calculate our mean SIA with
Yes.
our own data. We used to put into the Dr. Warren Hill's calculator. But now with Dr. Barrett and Warren Hill's advice, anything 2.4 or less incision, they recommend a flat centroid value of 0.1 to be used.
That's
so
right, yeah.
we have stopped calculating our own SIA, and we're using 0.1.
Where do you move your incision? Is your incision
No,
fixed?
our incision is always fixed temporal, no matter whatever the
Okay.
astigmatism of the
Okay.
patient is.
So if you do that, then the centroid value makes sense. But
Yes.
if you always operate on the steep meridian,
Yeah.
then the two actually coincide. They're
Right.
actually exactly the same. So
Yeah.
I operate always on the steep meridian.
Dr. Kishore.
Okay.
And
No, I
hence,
mean, I just operate only on a temporal. I mean, my incisions are 170 and 10, and probably
Yes.
that comes very close to the centroid, and I just put as a 0.2 is my surgical induced astigmatism that I calculate.
okay. So in general terms, I tend to, as Shell says, I just tend to ignore it because at most it's about 0.3 diopters in my hands. But because I always operate on the steep meridian, it's much easier to work that out. But if you have it, if you do, many people do, they do it always on the temporal meridian at 180, and hence you need all the vector calculations to work out your SIA.
But
Dr.
how
Milind,
about
before
for
we go
an-
ahead, can
I
you go
mean-
back to the, I'm sorry.
Yeah, I mean, how about for an, I mean, when you have an oblique axis, then I mean, how
Say
do
that
you-
again?
When you have an oblique axis,
Okay.
I mean,
so
oblique
when I have
stiff
an
axis,
oblique,
then-
so when I have an oblique axis, the two approaches I take. So I can't operate supranasally, for example.
Yeah.
So
and
the-
you can't operate inferior temporally also.
Indeed, it's the same thing, isn't it?
Yeah.
Infranasal,
superior nasal is still
Yeah.
superior nasal is still you given a block and still you can operate. But I mean,
Sure.
when you're doing an topical,
So-
you can't go in inferior.
So there are two
inferior
ways I
temporal.
do that. Two ways I take that approach. I do a 2.2 millimeter incision, and I put it in between the two, so it's at 45 degrees. So the idea is, whatever vector effect, they're spread equally on the two meridians. The second approach at times I do is, I operate on the flat meridian and add the SIA to the total astigmatism to be corrected. So that's another way. But
Okay.
because it's always at rectilinear, it's very easy to do the mathematics.
You're right. Yeah.
Dr. Milind, I'm very sorry to go to the basic question, but will you please explain this diagram to our delegates?
Okay, so this is what's called a double angle polar plot. So this is 360 degrees rather than just 180 degrees. And the idea is you plot the patient's astigmatism on the two meridians. So the circles are the magnitude. This is half, 1, 1.5, and 2 diopters. And the meridians are taken from there. So patient A has there, patient B is plotted there. And if you take the two means of that, you get the centroid value, which is, so it takes into account not just the magnitude, but also the meridian of the effect. And when you summate the two, that's how you come up with the centroid value. If you just do a straight calculation of just the magnitude effects, you will get a totally different value, which works okay if you're operating on the steep meridian all the time, but if you're operating temporally or anywhere else, then you can't use that, or you shouldn't really be using that value.
Thanks.
So we know posterior corneal astigmatism on average is half a diopter with the rule. That's the commonest pattern that we see. And hence there are two approaches. You could undercorrect with the rule astigmatism by half a diopter. You could overcorrect against the rule astigmatism by half a diopter. Or you could target for half a diopter with the rule astigmatism. It's all the same thing. It all works out in the same thing. So these are crude rule of thumb approaches to doing this kind of thing. Then there are some more sophisticated approaches that have come through recently, the Abulafia-Koch regression patterns, you got the Barrett-Torek. Both of these incorporate posterior corneal astigmatism as such. And it would be a good time to talk about how important do you think it is to do this, to take in posterior corneal astigmatism calculations. It is half a diopter in the end.
No, but still it's very important because this is an inherent 0.5 diopter. there can be other mistakes in while measuring astigmatism which can add on to it. When toric IOL started, everybody started putting, but never knew what's going wrong, you know. So how many it amounts to? It may not eventually be a 0.5. It may go up to 1.25 after, including measurement error, dryness. So many other issues are there. This issue has to be tackled because this is fixed. Like posterior corneal astigmatism, vertically negative throughout your life, which we know. So why not to correct it as a primary correction? This is what I feel.
Okay. Any other views on that?
I think, yeah, absolutely correct. We have this knowledge, and it's also been shown in literature that using this method is far superior in terms of refractive outcomes.
Dr. Sarvata, please.
Yeah. Actually, posterior astigmatism may be more than 0.5 also. So it has to be taken into consideration, and these newer formulae, they do correct this, have the corrective thing in them, inbuilt in them.
The range is 0.3 to 0.7. That's the common range in most of the population.
The only thing is we are just converted because these are the mathematical calculations. It's not real value that you measure within a tomography or what. So probably still we calculate within a lot of data, or even in a Hill RBF. You know, I mean, you just calculate a lot of, you know, your mathematical calculations. Both the formulas, they work on that. But I mean, let's have a realistic posterior corneal astigmatism value, and then you put into within a lot of database, and probably we'll have a better answer for that.
So we tried to do that. We went to Dr. Shell's conference when Dr. Varanil had come, and we said that we have a sham fluke imaging, and it gives a value of say a SIM-K 3 mm, 5 mm, 7 mm with the posterior K value. We said that values are not valid.
Yeah. In fact,
it's not been validated at all.
Correct. In fact, Dr. Barrett recently presented in ESCRS 3 different data sets where he showed that using his own values of incorporating the actually adding the posterior corneal value versus using the algorithm is superior.
Is better, yeah.
At least as of now. I'm sure with times it will change.
The posterior corneal astigmatism measured by corneal tomography is not going to be as accurate as by corneal topography. And that's a basic problem with it.
Yeah.
There are topographers available which do that. We use the Galili G4, which works quite well in my hands. And that has a ray traced total corneal astigmatism because the anterior surface is done by Scheimpflug, not by Scheimpflug, by Placido, by topography, and then the posterior surface is by tomography as such. So this is currently commercially available. This is the best you can do if you want to use total corneal astigmatism. And obviously, one thing to remember is if you're using total corneal astigmatism values to begin with, you should not use the other formulas because that will already add a correction onto it. But so if you use this to measure the amount of astigmatism you're going to correct, you should not use the Barrett or the Abulafia cork because that'll double the amount of correction you're putting in.
Yes.
But are you using this in your practice, sir?
This is what I use all the time.
And how are the results?
I'll show you.
Just a clarification. Now the Barrett's new version also has 2 options. So if you want to use the posterior corneal values, you need to select that version of the calculator. So you can use both in the Barrett now.
So the other thing that comes in is calculations. When you go around calculating and you have to decide, you have to go to each and every company site and then put the calculations if you want to choose which lens to put. But there are a couple of ways. This is the old Alcon calculator and the Bausch & Lomb calculator, and both these use what are called average fixed eye ratio calculations. So the lens plane to the corneal plane conversion is done by a fixed rate, which is not necessarily the most accurate way of doing that because this paper showed that if you actually use an average fixed eye ratio, you tend to overcorrect the cell because the actual effect of the intraocular lens plane correction into the corneal plane is dependent on the anterior chamber depth and the corneal curvature as such. So effective toric IOL calculations, if you do the sums, this is the formula that you need to do, and it differs with the anterior chamber depth and the spherically equivalent power on the intraocular lens as such. The AMO calculation takes into account and does an individual eye calculation using a Holiday formula as such. And the Zeiss system has its own individual eye formulas, which again corrects on an individual basis rather than an average basis. So you have to keep this in mind. And Alcon finally last year made the corrections necessary, working with Graham Barrett to work out the individual eye calculations and put in the other corrections that were required on that as such. I also use a universal calculation method, and this is a very simple way of doing it because I hate spending time with multiple calculators to work out what I need to use. And the simple way of doing this is you do the calculations for the intraocular lens in a cross-cell format. So you calculate lens power using K1, you calculate lens power using K2. The lower lens power gives you the sphere, and the difference between the two will give you the torus, the magnitude of the astigmatism. And this works for any lens. You know the actual lens constants, and if it's personalized, it works very well too. So just as an example, if you have a K1 power calculation of 25.5, K2 is 23.5, in the cross-cell form, you would write this as 23.5 and 2 diopter of cell. In the spherically equivalent form, it will be 24.5 and 2 diopters of cell. Take your pick, it's the same lens. So this is a very simple way of doing it. It's a very easy way of doing it, and you can apply this to whichever calculators you want to. There are certain limitations to this because of the actual lens designs as such, but for lots of purposes, for relatively small levels of, if it's less than 3 diopters, it doesn't make a difference. And this is very simple and easy way. I don't know, anyone use this?
This is very amazing. No, I not use it, but it's very practical. I don't know, it's very...
It's very simple.
Okay, yeah, absolutely.
Okay, so you measure, let's say the corneal power is 43 in K1 and 45 in K2. So you do the intraocular lens calculations by putting in K1, K2 as 43. Do the calculation, then for the steep meridian. So all you're doing is you're solving the equation in a cross-cell form for the lens plane. And it's very easy to do, and it works very well. This is basically Jack Holliday who taught me this, God knows how many years
That's
ago.
great. Absolutely great. But we have 5 minutes more, so instead of going with the panel discussion, if you can just tell us the key points, I think it will help us in our practice.
Sure. So we talked about this. So when you're doing astigmatic corrections, what we're talking about is to put a lens. So we have an option of putting it in the spectacle plane, in the corneal plane, which is a direct curvature change. But when you're putting it in the toric IOL, you're putting in a torus element to counteract another torus element. And the moment you do that, it becomes subject to centration, tilt, and rotation. So centration, tilt, and rotation will add effects of coma and astigmatism on its own right. And we have all these different types of lenses. You have monotorics, bitorics, all kinds of designs. And there's also labeling issues which are different. Zeiss will label their lenses in a different way, and others would do it in a different way. So the spherically equivalent calculation or a sphere and cell labeling also comes through. So you have to be careful when you're choosing these things. But I got caught out when I shifted from a Zeiss model to an AMO model, and I ordered the same lens, but it was a different labeling, so you have to be careful with that. So spherical targeting, we've talked about this before, but when you do toric lenses, the spherically equivalent targeting is not as accurate as you can with your spherical lenses. And there is a good reason for that, and the good reason for that is that every sphere of the lens has a different component on the sphere, on the lens as such. So the higher toric powers result in more myopic outcomes. And one of the things we look at for doing this is as to whether a lens is monotoric or bitoric. What we mean by that is a monotoric lens will have the full torus on one surface. A bitoric lens will have half the torus on the front surface, half on the back surface. So when you have the torus on the front surface, the optical plane will shift anterior and give you an effective lens plane error, making it more myopic. If you split half and half, that remains the same for all spherical powers, and that doesn't change as such. And we actually showed this in refractive outcomes for monotoric and bitorics, where we found that the bitorics were much more forgiving and gave us better spherically equivalent targeting. Alignment. So this is now we've measured everything, we know what to do, we know what lens has got to go in, and now you've got to put the lens in its correct position. And we're all familiar with these things and the various systems that are available, and Shell took us through some of the alignment systems. This is what I like to do. This is what I've been doing for about 20 years now, which is I do what's called a manual. So what the Verion does automated, I do manually. So on the slit lamp, you get the patient to fixate on your slit lamp light and identify limbal blood vessels and align the slit to those blood vessels and make a diagram to say where the meridian of that blood vessel is. So you got your 2 or 3 reference point markings as such. And you then use those reference point markings. So I draw a diagram like this in my notes, and I have that diagram in theater, and the first thing I do is to identify those 3 markings. It's at 30, 180, and 130. And again, there's always a little bit of fluid, so you get all these things, but you know where that marking is. So you mark the 3 blood vessels, and then the rest just falls into place. So you can do this during the pre-op assessments. You don't need to mark the patient on the day, or you don't need to worry about any of that stuff. Yep. And then on the day, you align those 3 markers and put the actual axis, the steep meridian that's identified on there. And the rest just follows very quickly in terms of that.
That's amazing. Absolutely amazing. Very good.
Once the lens goes in, the other option that happens is, especially when you're using these plate haptic lenses. How much time we got?
So another 2-3 minutes. A small question. When we put a marker, before putting the lens, we put a mark. Suppose say 110 degree, we put a marker. Actually, when we put the IOL inside, the markers, both the ends, don't coincide. So we are not sure many a times whether to align with the lower marker or upper marker. Does it happen with anybody?
Yeah, I think it's universal.
This has not been discussed anywhere. This has not been given anywhere.
Okay.
But I don't know.
I think this is a very important thing to think about. So we'll go through this case, but there's one particular paper. Everyone familiar with astigmatismfix.com and how to work out what you need to do if you've got to rotate early. And this is a key paper that I think opened my eyes to how important something really is. So astigmatismfix.com did an analysis of all the data that was put onto their website to see what the results were. And what they found was this. They found that if you look at the intended versus the oriented, so where someone wanted to put the lens, was the lens put in that place? And then you do back calculations to work out whether that lens was in the ideal orientation, which meant if by rotating the lens you could not improve the astigmatism beyond a certain level. Okay? So when you look at the data here, only 6% of eyes were the lenses in the ideal orientation, and they were as intended by the surgeon. Okay? There were 6% of eyes where the lens was not in the intended orientation, but was in the ideal orientation. So the way we look at astigmatism is very simple, and it's a very simplified way of doing this, but the complexities of astigmatism mean that it's not as easy to do as we think it should be. So I don't think we'll ever get beyond the kind of 85, 80% astigmatism corrections that we do, unlike the other thing. If you haven't got time, we don't need to go through these cases. I'll tell you what, let me just do just one case right at the end, this one. one of my most interesting cases. So this is an Irish gentleman who had bilateral cataracts, refraction was that, had previous LASIK for very high levels of myopia and astigmatism, God knows where, and retreated and everything, and he was 612 plus, reasonably happy. So we did his workups. He had 1.8, 2.1 diopters of astigmatism, and I started off by treating his first eye, and we put a toric lens in. So after the right eye, once the first eye was done, he ended up with 2 diopters of corneal astigmatism. So it's as if there was just no astigmatism that was there. In other words, the topography was showing 2 diopters, but there was no astigmatism as such because of the previous corneal surgery. So for the other eye, I ignored the 2 diopters on the topography and just put a spherical lens in, and he ended up wonderful. So you're saying, okay, now what are you going to do with the other eye, the first eye that you did? So the options were you could do an IOL exchange. I could take the lens out and then put it in, or I could do a sulcus piggyback toric, and that's what I chose. But because it was quite a high correction, I chose a phakic ICL to do, and overall his vision improved, but he started complaining of halos. So with these halos as such, any idea why this was happening? And these halos are occurring because of that central hole on that ICL. That's the reason why he was getting the halos. So I had to swap that ICL for an ICL without a hole, and he was absolutely happy. So again, it's not necessary to do an IOL exchange. You can put piggyback IOLs as such. So I'm hoping we would have done this today. I'm sure you're all familiar with the ways people describe elephants, but when we have enlightened panel as such, I hope the audience has realized that we're not talking of a snake or a tree trunk or whatever, but we're actually talking about the full astigmatic elephant. Thank you.
Thank you, Dr. Milind. It was really great. It is going to help all of us. Such a practical points and such a huge data you are having for such a long time. Thanks a lot. May I request Dr. Sanjay Shah to give a token of appreciation to Dr. Milind? We have only 5 minutes of tea and coffee break. Thank you.